Welcome, everybody. This is SOMA Living, the standard of modern living. Welcome back. Today, we're actually going to talk about credentials. So what does that mean? It just basically means are we qualified to do what we do, and who else is, and how do you know, and what does that mean, right? It's kind of a big topic. We really want to get into the nitty gritty. We're not going to get that much into the weeds.
Right.
But there is a lot that goes into producing a plastic surgeon in any subspecialty of medicine. They're different. It's different training.
Right.
So everyone has different training. So if you say you're a plastic surgeon, it's one kind of training. If you say you're a dermatologist, it's another kind of training. Gastroenterologist, cardiologist, all of them have very specific training. And it all comes off from one common point, which is obviously med school, and then internship, which already there's a division of two different kinds, and then it spreads into other things, right?
Yeah. I think a main point too for you guys is to kind of demystify, because there's a lot right now, there's a lot of different clinics, there's a lot of different practitioners that are calling themselves different things, and it gets very confusing.
Yeah, it is.
Yeah.
Even for me sometimes.
Yeah.
I look at something like, what is this guy's training? You have to do a search to figure it out.
Even we have to dig sometimes.
Yeah.
And so it's not easy out there.
No. And they don't make it easy. I mean, in terms of marketing, there's so many things that are allowed. I mean, marketing is a relatively new thing for me too. Since in the beginning, we weren't even allowed to do that. But now, obviously, it's all about marketing.
Correct.
And so that comes also down to truth in marketing, and credentials is a part of that, as far as I'm concerned.
Yeah. So for plastic surgery, there are two main kind of training tracks right now. Why don't you talk about, Dr. Rogers, the track that you did?
All right. So there's basically two kinds, but there's some little variations on that too. So there is, we call the traditional tract, which basically means you go through general surgery first. And general surgery is, it's knowing how to do hernias and bowel surgery. And it's mostly surgery from here to here, but there's other things too. You learn to do thyroid. You do, it's the bread and butter of surgery.
Right.
And from there, a lot of people will subspecialize into things. So that was the original way. Pretty much everyone went into everything. So I did general surgery first. However, I didn't do the full 5 years. So normally it's 5 years of training.
Right.
I did 3 years of training plus a couple years of research. And then I went into the plastic surgery tract.
Right.
So that is more the traditional route, but it's still not 100% the traditional route.
Yeah.
And you did the newer way they do it now, right?
Right. So that's called the integrated plastic surgery residency route. And so that's right out of medical school. You apply to plastic surgery residencies. Now there's a bunch. It used to be that there was 20 integrated programs.
I remember.
When this when plastic surgery kind of started becoming a training program. And so now there's hundreds of integrated plastic surgery training programs. So you do 1 year of general surgery internship pretty much across the board. And that's everything from vascular to ENT to thoracic and cardiac and general and trauma and all of that.
But that's still a general surgery internship.
Still a general surgery internship.
So that's the same for everyone going into a surgical subspecialty.
Yeah. Pretty much you need to do that hands down. That just gives you that kind of depth and breadth of surgery and just you get a little taste of everything.
And you know how to communicate with your colleagues. They're subspecialty. You need you know what they do. You know what they're. You have to get a consult for something. You know who to call and why.
It's important.
Yeah.
And then from years 2 through 6, that's when things start to be more geared toward plastic surgery. Because like you said, it got to the point where plastic surgeons or people who wanted to become a plastic surgeon were doing this 5-year general surgery training, and they were in the belly for 80% of their 5 years in general surgery, and it's just not useful. So kind of trimming some of the fat per se, and then focusing more on plastic surgery related things. So you're taking plastic surgery call, you're seeing face traumas and hand traumas, and you're doing all that starting as a second year for the most part.
Well, that's exactly why I only did 3 years. I didn't want to do the second 2 years. You're learning things like how to do a Whipple procedure, which is it's like you're taking out a piece of the pancreas and replumbing everything.
Yeah.
It's a big surgery.
Yeah.
And I knew if I went to plastics, I would never, ever do one of those.
Yeah.
So why spend 2 years learning how to do it well when you're never going to use it?
Yeah.
And there's almost no crossover skill. All those crossover skills, like sewing bowel, I already knew how to do.
Yeah.
So it's obviously that logic has stood the test of time, hence all these combined programs.
Yeah.
When I did it, I did general surgery for 3, so we did have a little bit of plastics exposure, but it was relatively minimal. It was like a little rotation here or there.
And I think what a lot of people don't know about plastic surgery, because people just think, oh, aesthetics, right? They think facelifts and they think, liposuction and breast augmentation, but there's so much that we have to learn. We're literally learning everything from cancer reconstruction to pediatric craniofacial clefts and all that stuff, and skulls, and then we're doing hand, and we're doing,
so much.
So literally head to toe.
Things.
That all these subjects that we have to learn and know every single little detail about. So that process takes time. So rather than like cramming it all in, now they're stretching it out over those 5 years. I think even some programs, actually, I think University of Pittsburgh, where we both trained, is now potentially cutting it down to 5. I know some residents are even graduating a year early if they're deemed proficient.
Oh, interesting.
So I think it's just becoming more focused, and they're trying to, again, just like eliminate the excess, too much.
Yeah. Well, I mean, you think that it's being a resident is interesting. You're like, as a resident, you don't get paid very much.
Yeah,
right?
No.
And so you're like, oh my God, we're slave labor. But, which there's some truth to that. We do a lot of work for very little. However, it still costs money. So the truth is we're not that cheap. So they have money that's allocated to them for these programs. And so if they can save money here and there and still put out really well-trained people, I think it makes sense.
Absolutely.
Yeah.
It just makes the whole process more efficient, in general. And then, so after those either 3 years in general of plastic surgery, extra training, or the 6 integrated, then you have the option of doing a fellowship. So plastic surgery fellowships, you can go into anything from hand surgery to craniofacial, pediatric, which can be bony pediatric or soft tissue pediatric. And then there's microsurgery, which is basically flap reconstruction, learning all the different free flaps and their reconstructive purposes. And then there's aesthetics. So those are the main. Oh, and then now there's also transgender.
By the way, plastic surgery training itself used to be just considered a fellowship.
Correct.
Because that's in the beginning. Because everyone did general, and then you did a fellowship in plastics.
Right.
But now it's a part of a residency program. It's different. All these fellowships, like cardiothoracic surgery was technically, all these were fellowships. Initially. And so, but now they've become sort of subspecialty residency tracks, and then there's fellowships on top of these for super subspecialization.
Yeah. And so we both did an aesthetic surgery fellowship, which again is a fellowship within plastic surgery. So that was another year. But at that point, you are a fully trained surgeon.
Yeah. Well, the reason I did it, you probably did it for the same reason, is in residency programs, you see a lot of reconstruction. Partially, you see all these other things you talked about: craniofacial, head and body, down to your toes, literally.
Yeah.
Free flaps, hand surgery, everything, but not that much cosmetic.
Yeah.
And if you know that's what you want to do, you want to be proficient.
Yeah.
So, and a lot of people don't get that fellowship.
Right. And I think that's another kind of misconception of the public, is that they don't realize that in our training, a minority is the cosmetic stuff.
Yeah.
It's mostly, we're taking like face trauma call, we're sewing up firecracker hands, we're, dog bites to the face, stuff like that.
But you really can't discount the value of all that, because that is the basis for everything we do, even in cosmetic.
Yeah.
If you don't know that stuff, honestly, I don't know how good of a cosmetic surgeon you're going to be.
It's the foundation. It's absolutely necessary. And it makes you, all these things make you a better surgeon. Then all those principles get applied to what we do every day in terms of, the cosmetic stuff. So,
right.
So then now let's talk about the different residencies or different kind of specialties that then can segue into a plastic surgery related field.
Yeah, so there are different ways to get there. Again, I said the traditional way is general surgery. And that's still kind of the traditional way, meaning your integrated program is basically still general surgery mixed with plastic surgery. Yeah. However, you can get to plastics through other routes like ENT. So you can. So there are people out there, different facial plastics. Those are fully ENT trained people who did a facial plastic fellowship, which is different. Yeah. But you can do full ENT training and then do additional full plastic surgery training.
Right.
And then if you want, you can do an extra fellowship. But so it's a little different. So you technically are not a board certified plastic surgeon unless you've done a plastic surgery residency.
Correct.
Not facial plastics doesn't count. That's different.
Right.
You can also get there through, say, orthopedic surgery. That happens. Neurosurgery, less common, but it can happen. Is there any other routes? I'm not sure you can get there any other way.
Yeah, and then now, and then ophthalmology, you can do an oculoplastic.
But that's not plastics.
Right.
So because the problem, you can't get into a plastic surgery program through ophthalmology because it's so subspecialized already.
Right.
All you're learning is essentially around the eye. Yeah. When you do oculoplastics, you're expanding that knowledge to more of the craniofacial skeleton and the soft tissues around it. So you're working from specialized out. Plastic surgery is the opposite. We were working from generalized in.
Yeah.
So we have a very broad knowledge, and then we subspecialize.
Yeah.
So it doesn't really work if you go the other way.
Right.
Yeah.
But I think it's important to kind of just distinguish that, because I think a lot of these guys that are oculoplastic surgeons that are doing blephs and brow lifts and mid facelifts and potentially even facelifts, it's a totally different route.
Yeah.
They're doing, I think ophthalmology is 4 years.
Yes, I believe so.
And then, so they're doing 4 years of ophthalmology residency, and then they're doing 1 year of oculoplastic fellowship. And again, that oculoplastic fellowship is soft tissue reconstruction of the eye and the orbital area, periorbital area, and some cosmetic applications too.
And the truth is, there's some very good ones.
Yeah, absolutely.
So we're not knocking it.
No, yeah. No.
We're just saying it's very specific to an area of the body.
So I think there's a news issue recently, or a news article that I saw in California particularly, where there was a group of nurse practitioners who had their doctorate that had been running practices or running facilities and calling themselves doctors. And there's a lawsuit between the state of California and these.
I saw that article.
Yeah.
Interesting.
So the verdict was that now in the state of California, if you have a doctorate as a nurse practitioner, you are still not allowed to call yourself a doctor.
Right.
And that's to preserve, the medical doctor title for physicians, and particularly in a clinical setting. So, what are your thoughts on?
It's interesting. I understand why it's controversial, because obviously, if you have a doctorate, you should be able to call yourself a doctor, right? And there are like therapists out there, for instance, who are PhDs, who are doctors, and they call themselves doctors, even though they're not medical doctors. Right. So I understand, but I also understand the other side of it too, because what's the point of saying you're a doctor if you don't at least have a certain idea of what these credentials mean? Yeah. So this all comes down to credentials, right? Yeah. So it's I think I agree. I mean, it's a difficult one, and I kind of understand. I mean, if you're a nurse practitioner and you do all this training and you have a doctorate, which is a lot of work, it's not like it was nothing. Right. You deserve to have some recognition for it. But I do think that maybe some line needs to be drawn, just because, not because of what you should be able to call yourself, but because what expectation you set with your patient.
Right. Yeah, and I think it also goes back to not misleading the public. So one of the interesting aspects of the case that they were arguing was First Amendment freedom of speech. Right. So that's where I think it got kind of a little dicey. Like I feel like this could be a whole another discussion about people kind of abusing the First Amendment, I think, or using that to just fall back on, saying that, I can just say whatever I want because I have freedoms. We need to draw the line somewhere, right? Yeah. And so I think that's where the court ruled, was that inaccuracy or misleading is not protected by the First Amendment, right? So for patients, for however they want to call them, they need to know that these are nurse practitioners and they're not medical doctor or physicians. And so I think that's where the verdict came from. And I see both sides of it, like you said. I think where it can get a little bit hairy is, like a doctor of like Jill Biden is like Dr. Jill Biden because of a doctorate in education. Right. So should she not be able to call, so it gets, a naturopathic doctor, all these, or chiropractic doctor.
Right. That's true. But I guess there's still sort of a physician-like status for it. to some degree.
Right. And so it gets a little...
Yeah, it does.
It gets a little dicey. But I think in the end, there's a difference between nurses and physicians. And nurses are extremely important in the practice of medicine. There's no denying that. But the training is very different. So I think there needs to be some differentiator. And I think that's where it comes down to. There's this plastic surgeon, I forget her name off the top of my head, but she actually started off as a nurse practitioner. So she does some posts and some, social media.
She went back to med school.
Yeah.
Oh,
So
that's the way you can get to med school too, by the way. You can go to nursing school first.
Yeah.
Instead of college.
Yeah.
So anyway, go ahead.
Yeah. So she does a lot of content on her experience as a nurse practitioner and now as a plastic surgeon, and having gone through both trainings of how different it is. And not discounting the importance of nurses and that profession in itself.
Yeah.
But she was like, it's so different. Like just the type of knowledge and the way you have to apply the knowledge. And the whole process, the whole education, even that whole is entirely different.
Another interesting thing though is there any difference medically legally in terms of liability?
Yeah, it's a good question. I think so.
Yeah, because that also matters.
Yeah.
Because there's you have to be accountable for what you do and all these other things, held accountable too. So I don't know. It's a slippery slope.
Yeah,
I understand the argument for freedom of speech, but I also understand you can't mislead people.
Right.
So, and then if you even that is a slippery slope. Like what's misleading and what isn't, what's opinion, what's, who's got the right answer. I mean, that's a whole nother thing. But sometimes when it just comes down to like a degree and a regulatory thing, it's kind of more cut and dry.
Yeah. Yeah.
So, all right. So we also wanted to talk about how do you actually pick your surgeon? So and that's kind of important. So it's not just your surgeon, but you're also your practitioner, whether you're looking for someone to do injectables or whatever. So, and that's a process that can be very difficult. I mean, honestly, if I needed surgery on something that I'm not an expert in, I would have a difficult time just trying to decide who's the best person for the job.
Yeah.
Now, luckily as a doctor, I know a lot of people who are qualified and can do a good job. But then you're like, oh, but I want to make sure he's the right one for me, or knows exactly this situation, or because medicine is not an exact science. It's not like engineering. It's not like mathematics when 1 + 1 is always going to be 2.
Right.
So in medicine, each patient is different. Each surgeon is slightly different in what experiences they've had and how that experience applies to you as the patient, and that will change potentially the outcome.
Yeah.
So it's hard.
Yeah. And I think so much of it too is these intangibles, right? Like when you go and meet a surgeon, or if you're following someone on social media or whatever, I often hear that I don't know why I chose you, but I chose, I just felt like you were the right fit, so there's a lot of that too. But of course, you want someone that's credentialed and has the experience and is well trained and is, appropriately boarded and whatnot. But yeah, a lot of it is, it's hard to put a finger on.
Yeah, but I mean, a nice person isn't always the most qualified person.
Yeah.
And just because someone's nasty or mean or whatever, authoritarian, doesn't necessarily mean that they're the best either.
Yeah.
So but we're humans, right? So we're influenced by all kinds of things.
Yeah. And I want to point out too, like all of what we're talking about in terms of looking up certifications or looking up licensing, this is all public information. So, if you guys are going to a new office and you want to verify that these people have active licenses and are practicing medicine appropriately and whatever board they're saying that they're under, that they're actually active under and have up-to-date credentials, that's all public information. So you can look up these things, Google them, find that, look up on that board website, and all that's there for you. So, it's available.
Right.
Yeah.
So that's just the first step.
Yeah.
I mean, that's, if they're board certified, then at least they've done the proper amount of training. At least there's some oversight as to what's going on. But ultimately, how good of a surgeon they are it's much more than that.
Yeah. Absolutely.
Yeah, you can be board certified and honestly still not be a great surgeon.
Well, that's true too. Yeah.
So you have to kind of pick all the little pieces up and put them together yourself to figure it out.
Yeah.
And it's hard. It's hard to do. And a lot of it also is, who do you click with? So it's not, you don't have to just like them, but also like you get to meet somebody. Is that your person? Because that has a lot to do with it. Because it's a team effort when you're going to get surgery or even injectables. It's a conversation and a relationship you're going to have with this person. It's not just like, you're hiring someone to clean your carpets. It's like it's a real deal.
Yeah.
And you have to click well with them. You have to understand what they're saying. You have to be able to work with them because working with your surgeon or practitioner is going to give you the best results.
Yeah. And I think it's important to highlight the fact that, you may be going to, say, a med spa for your fillers and your Botox, which is fine. But in the end, like you said, in that same vein, like this is real medicine. These things can lead to real complications, and you want to go somewhere that can deal with all that. And one thing too that I wanted to bring up is we are very diligent here. If you see one of our nurses, this is truly a medical practice in the sense that if you see one of our nurses and you're getting treatment, and you're a new patient to the practice, you will always undergo what's called a good faith exam, which more or less is an abbreviated history and physical, which is the standard in medicine in terms of a new patient intake, learning everything about you and making sure that a treatment is safe for you. So I think it's really important for the layperson or for a new patient to acknowledge that too, that if you are going in somewhere and they just start shoving filler in your face without even really taking a history on you and knowing who you are as a patient, that's certainly a red flag.
Oh, it is. I mean, it doesn't mean you're going to have a bad result because the truth is most people out there are good candidates for fillers and lasers and things. However, if by chance you're not and they didn't check, then you're going to have a bad outcome.
Yeah. And these are real medical treatments, right? Like it's not... And I think that's where we get a little laissez-faire with some things in general, just some practitioners do. But I think it's just so important to just know about that.
Yeah. And by the way, they're supposed to do it. It's part of the regulation. I mean, if they're not doing it, they're not compliant.
Right.
And that's actually a big deal.
Yeah.
All right. So another thing about being credentialed also means that you have to keep your credentials current. And that means you have to prove that you're continuing your education, keeping the education that you did get up to date and current, which also means not forgetting stuff because if you don't use it, you forget things. And just because you don't use it doesn't mean it's not important. Like, for instance, I haven't had to perform CPR on somebody in years, not since residency. But I sure as hell better know how to do it.
Right.
So I mean, that applies to all kinds of things. Fillers, for instance. If you've never had an occlusion, okay, great, you've never had one. But if you do, you better know how to treat it.
Yep.
So these are all things that are part of our continuing education. And as things develop, meaning we gather new data.
Yeah.
We know things like the science in the field changes. We find out like, oh my gosh, we need to change the way we do things. You should know this stuff or you're not up to date.
Yeah. And that's why we always say practicing medicine is called practicing medicine for a reason. Like we're always just practicing. You're constantly... The field is evolving and we need to stay on top of that. And whether that's through virtual education sessions or national meetings that we attend and listen to other experts and our colleagues talk about the latest and greatest new things, all these things are just so essential to keep us on our toes for your safety. I think that's really what it comes down to.
I mean, so they call them CME credits, continuing medical education. So that's, and a lot of different professions in the world have these type of continuing education type of things, but medicine, it's really important. In fact, you can't even maintain your board qualifications without it. You have to have a certain number every year.
Right.
But it's all over the place. It's not just like, a new technique, but it's also, and it's not just even safety. There's other things too. Like for those of us out there who understand, and any doctor out there does, they have courses on like, how do you run a practice? And that's really important because your experience is going to be dependent on, that first minute you step in our door or possibly the first minute you call us. Like how does that call happen? Or do you get calls back? How are you received? When you walk in, are you sitting there waiting for hours for your appointment? Do people let you know when stuff, when you need, there's about information you need to know, like lab work and things like that? These are all part of it. How are they taking care of your personal information? There's all like HIPAA's a whole other thing. That's in terms of patients' privacy, in terms of their medical information. These are all things that need to be taken seriously. Yeah. And these are all things that are sometimes not done well.
Yeah.
And so CME is a part of that as well.
Yeah.
So, and it all comes from the top down. So whoever runs the practice, owns the practice, who presumably is at least to some extent running the practice, sets the expectation, and everyone else has to follow suit. That's one of the risks, I think, of these standalone med spas that don't necessarily have like a medical director that's there, because the people making these decisions aren't the people who are taking the CMEs, who don't necessarily even know what the regulations are.
Right.
And they're running it more like a hair salon versus a medical practice.
Yeah. It's one thing that I just thought of, which I know I've been trying to get our nurses to do, is one of my pet peeves is hearing practitioners call their patients clients.
Yeah.
This is medicine. Like, you are patient. You are our patient, you know, and I know sometimes people just get accustomed to calling them clients, but no, like, you're a patient. This is not a hair salon. This is not a nail salon. This is not a massage parlor. You know, you're not a client. You are, this isn't, you're a patient.
Yeah.
And this is medicine. And I think it's important, even though it's semantics, but I think it's important.
I agree.
Yeah.
And everything we do has risk.
Right.
Every single thing we do has at least some risk. I mean, some of them are really small, but I mean, we go from the mind and most mind, because we have like lymphatic massage therapists. The risk of a lymphatic massage session is pretty small, but it's not zero. Anytime somebody touches you, there's some risk.
Yeah, of course.
And of course, we do the opposite end too. We do major cosmetic and some reconstructive surgeries too that are significant with more risk.
Yeah. And even if you are seeing our nurses or our nurse practitioners or our PA, those practitioners are practicing under us. And so you're essentially our patient.
Yeah, absolutely.
Right.
Yeah.
So, yeah, I think it's important.
All right. So I guess that wraps up credentialing. You know, we've kind of gone over what is credentialing. We've gone over like why it's important. Like how do you even get credentialed? And if you have any more questions about it, please contact us. I think the biggest takeaway is whoever you decide to use as your surgeon, doctor, practitioner, just make sure that they're qualified. And being qualified, a big part of being qualified is having the right credentials. It's not the only part, but it's definitely a significant part.
Yeah, and in the end, all of these measures and protections are set in for your safety, and we want you to be safe, and that's why we're talking about these things. We're talking about these things to kind of demystify some of these very confusing titles and, this ever-changing kind of scope of medicine. And so again, we want you to be safe. We want you to be happy with your results. And so hope you learned something.
And remember, the reason it's confusing is some people out there want it to be.
That's true too. Yeah.
So we're trying to make it less confusing.
Yeah.
All right. So thanks everybody. See you next time on SOMA Living.